So I think the biggest stereotype of surgeons is that they're mean or ornery. But we're nice people just like everybody else. There's maybe one or two bad apples in a bunch, but we're all nice guys. And so I'd say that's the biggest misconception I've really encountered.
Hi everyone, welcome to episode 6 of The Breakdown with Rothman Orthopedics. I'm your host, Atif Ahmed, and excited to be back after a brief hiatus with a look at what it's like to be in the operating room. We're going to do a roundtable discussion with 3 of our Rothman surgeons, Dr. Atif Ahmed. He's an orthopedic trauma and fracture care surgeon at our newly formed Rothman, Florida practice. Dr. Chad Krueger, he's a joint replacement surgeon based here in Greater Philadelphia. And Dr. Dan Siegerman, hand and wrist surgeon at Rothman, New York. So if you've ever wondered how a surgeon preps to go into the OR and other burning questions, this is the episode for you. I'd like to welcome in Dr. Dan Siegerman, Dr. Atif Ahmed, and Dr. Chad Krueger. So Dr. Seigerman is a hand and wrist surgeon and part of Rothman, New York. Dr. Krueger is the joint replacement surgeon, is based in Greater Philadelphia. And Dr. Ahmed, he's a trauma and fracture care surgeon, was formerly based here in Greater Philadelphia with Rothman, but now is the newest member of our Rothman, Florida team, and is a part of our partnership with Advent Health. So want to thank you all for joining me today. And you all come from 3 very different subspecialties, so I thought it'd be, kind of awesome to get 3 very different perspectives on what it's like in the operating room. And just to kind of get things going a little bit, I thought it would, definitely be acceptable for all of you just to kind of give a little bit of a background about yourself and just kind of the path you took to become a surgeon. So who'd like to begin and kick things off? Don't be shy.
Sure, Alex, I'm happy to start off. Thanks for organizing this and bringing us all together today. So like you said, I'm Dan Siegerman. I'm a hand and wrist surgeon in New York, and the Rothman offices in New York City and in Westchester. I wanted to become an orthopedic surgeon basically because I was exposed to medicine from watching my father as a dentist. He would sometimes bring his cases home and talk to me about it and sometimes bring me into his office, and I thought it was great. And I saw how he interacted with patients and how they loved him, and he was able to help them. And then throughout school, I spent some time with an orthopedic surgeon when I was in college who sort of showed me about, orthopedics and what it was all about. And from there, I went to medical school for the purpose of becoming an orthopedic surgeon. I did my training in Newark, New Jersey, which was a heavy trauma center. And then I actually did my fellowship at Rothman in Philly. With some of the greatest hand and wrist surgeons in the country. So that's what brought me to do what I do today. Great.
Let's kind of, since you mentioned that you did a little bit of a trauma background, why don't we just kick it off with you, Dr. Ahmed?
Okay, so I'm Dr. Atif Ahmed. I'm an orthopedic trauma surgeon that specializes in fracture care pretty much almost everywhere. Medicine wasn't my first career. I ended up becoming a dentist first after college. And so I was really interested in just going through 4 years of school and then being able to start my work. And like towards the end of my dental school, I got interested in surgery and thought about doing OMFS and then wanting to fix fractures. And I realized that after dental school, the training was going to be like 6-7 years to do OMFS. And I figured if I got to spend that much time, might as well just do orthopedic surgery and I can fix everything. So that's how I ended up doing it. And so I did my residency at Montefiore Hospital in the Bronx in New York City, which was really a great experience because you get to take care of everybody and you see everyone. And then did my fellowship in Pittsburgh, and I've been working at Rothman for the last 3 years, mostly in Philadelphia and now the last few weeks in Florida.
Great. And last but not least, Dr. Krueger.
Yeah, thanks for having me today, Alex. So, I think I was exposed to orthopedics a lot on the patient aspect when I was younger. I talked to my parents about it some, and my dad couldn't figure out why I wanted to go back to school. But really, ever since I was a freshman in high school, I kind of wanted to be an orthopedic surgeon. And, I took, all the same classes as everyone else. My only difference being that I joined the Army. So I was part of the Army in residency, and then I was a general orthopedic surgeon for them for about 4 years after residency, doing some sports, trauma, and hip and knee replacements. I really about everything except much foot and ankle. Never really enjoyed that. And then after that, I went back to a fellowship here at the Rothman Institute, and then had the opportunity to stay. And that's certainly not an opportunity I would turn down. So My family and I have enjoyed Philly and, really enjoy serving the patients of this community and look forward to our future here.
So it's actually interesting just kind of hearing everyone's, background, but there seems to be kind of a little bit of overlap. So it seems like everyone has had their little taste of the trauma life. So would you say, is that something that most surgeons get exposed to? Is it, I'm curious to know, why you all decided, to kind of end up in your subspecialty and, maybe you've kind of danced around in a few other ones and then kind of ultimately ended up. So just curious to know about that a little bit more.
I think that's a fair question. Certainly, all of us have our interests and certain patients that we tend to, either bond with the most or feel most comfortable caring for, or even some of our favorite cases. But certainly trauma is a part of everyone's career here to a degree, at least for the most part. We all feel comfortable taking care of general trauma. I think most of us take call. And the bottom line is, broken bones are what the basis of orthopedics is.
Yeah, I totally agree with Chad. I think trauma is the backbone to orthopedics. And when you can do a really great job with trauma, some of the more elective things, sort of come a little bit easier as you master, taking care of really complex fractures and really traumatically injured individuals. And for me, going into hand surgery was sort of shocking. I thought I was going to be a joint surgeon. But, when I was exposed to hand surgery, I was intrigued by the sort of intricacies of the anatomy. And I also really like the diversity in what we do. So, on a typical day, we can do fracture work, we can do, joint replacement or reconstruction work, fix tendons, work with nerves. And so the diversity of the type of surgery and the type of patients, whether they're adolescent, really young, middle-aged or elderly, we have each of those age groups have various things that, can go wrong in the hand and upper extremity. So sort of what drew me to hand surgery.
Awesome. So what would you all say, what is kind of like the biggest misconception about being a surgeon?
I'd say what I've encountered sometimes is that people will meet me and they'll say, "Oh, Dr. Ahmed, you're a really nice guy." And so I think the biggest stereotype of surgeons is that they're mean or ornery. But we're nice people just like everybody else. There's maybe one or two bad apples in a bunch, but we're all nice guys. And so I'd say that's the biggest misconception I've really encountered.
That's true for probably any profession too, right?
Yeah.
Go ahead, Dr. Krueger.
I would just second that. I think all of us, we care a lot about our patients. I think it'd be like trying to explain how much you care about your child to someone who doesn't have kids. Is trying to explain, whenever your patients do well, how happy it makes you feel. And if they have a complication, you feel that equally. So I think, really understanding how personal, medicine is and surgery is for a lot of us is really difficult to explain.
I also agree. I think that, one of the funniest things I ever hear is when someone leaves a message for me and I call them back and thank you so much for calling me. And, of course I'll call you back. It's a basic thing. You have a question, we can answer it. And, we like to be available. And I think people have that misconception that, we're not going to return their phone call. We're not going to be nice, like you guys have mentioned. We're a really nice group of people. Our staff is really incredible. And we spend a lot of time with people. Another thing that I think is a great misconception in surgery is that most of my patients don't have surgery. People think they come to see me as the orthopedic surgeon and they're going to need an operation. A lot of what I do could be treated non-operatively. And certainly, many people do need surgery. So when that's necessary, we're ready to, use the latest and greatest techniques. Many people can get by without an operation. That makes me very happy too.
So I would definitely hear that because I think that's a lot of times when we hear patients, they automatically don't want to get their hand or this issue checked out because they automatically think that the first step is that someone's just going to cut them open and that's just the resolution. So I think, and correct me if I'm wrong, Dr. Ahmed, that's probably a little bit different in your subspecialty, but Dr. Krueger, would you say that's kind of similar to you? Like you kind of go to the conservative treatment first before you decide on operating on someone?
Yeah, without question. And I'll be honest, the hardest patients for me in the office are those who really want surgery, and I'm trying to talk them out of it because I don't think it's necessarily the best step in their treatment algorithm. So 100%, the majority of the folks don't get surgery or, they get surgery after they've tried everything else. We want patients to get better, right? And one of the common things I say to my patients is, I can always make you different, but I can't always make you better. And you try really hard to select those patients that you feel surgery will most likely make them better.
Yeah, for sure. And I completely agree. And even in fracture care, there's a lot of broken bones that don't need surgery. And so, I really try my hardest to stick to really good indications for bringing people to the OR. Because if you can heal and come out the same without surgery, then why go through all of that pain and hassle and expense if you don't have to?
Would you actually, I'm interested in just hearing, so what you say that, because that actually surprised to hear me that a lot of people don't actually need surgery. But so what are some of the cases that you would say come across your lap and you're like, what, we can just do it, fix it X, Y, and Z, or, some of the situations where surgery is absolutely not needed?
Yeah, so for me, if somebody has a fracture that's not displaced, let's say the collarbone, the clavicle, or the distal radius, those are things that definitely don't need surgery, and so they can be immobilized appropriately. The body will heal those fractures, most of the time. And just going in and putting plates or, hardware in there to hold it together is not really going to change the final outcome. And it could, ultimately cause complications and make people worse. And so, you really got to stick to really good indications to decide who to take to the OR, because those are the people that you're going to really help.
Awesome. So I'm sure you guys are, have many different procedures. And again, I know we're speaking a little bit about the OR, so kind of want to stick to that theme a little bit. But what would you say is probably the one procedure that you're really good at, or that you enjoy performing, whether it's you're seeing the results right away, or it's just something that you're just really good at? And that's fine if you're really good at it. And it's fine for you to say that you're really good at. So just curious to know about that.
Yeah, I would say really any primary or revision hip are probably my favorite. I think, certainly hip arthritis patients are, when it's severe, it's quite miserable. They have a hard time doing really basic activities, and being able to replace their hip and literally change their life in the span of 8 hours. If you include the surgery and their time at the hospital and their initial recovery, they're already feeling better at that point. And that's pretty gratifying to do. And it's the same thing with anyone who needs a revision of the hip. Again, those could be really complex cases that are, technically demanding. They're certainly a challenge, many of them. To be able to do those successfully and again, change someone's life is quite impactful.
For me, as a hand surgeon, there's so many different operations that I do. And some of what I really enjoy, some of the super complex surgery, really transforms someone's upper limb and to give them back function. But interestingly, what I think is one of the most successful operations is a standard carpal tunnel release. It's a very quick operation. It takes about 5 to 10 minutes to do, and it's done to treat people with numbness and tingling in many of their fingers. Often these patients can't sleep at night. They're woken up many times throughout the night and have to shake out their hands, and they're miserable. Think about if you lose months of sleep and you can't drive your car without your hands falling asleep. You do a 5-minute operation, and oftentimes, it's mitigated, either completely gone or greatly better. So for me, that's a really small operation that does really well. Probably one of the most gratifying things that we do.
And for me, I really enjoy treating fractures around the ankle, distal tibia, the complicated intra-articular fractures known as pilon fractures and ankle fractures. Every fracture is completely different. There's a myriad of different ways to fix them and to get to where you need to be, and the anatomy is different depending upon how you do it. And these people, there's not a really great bailout for them if you're not able to do a great reconstruction at the time of their initial injury. And so it's, lots on the line, and it's really gratifying to be able to get these people back to their function and pre-injury function afterwards.
So I'm actually just kind of going a little bit deeper, interested to find out if there's any sort of, in your subspecialty, any sort of interesting procedures, not necessarily your ones that are your favorite, but kind of maybe whether it's technology related or, just anything, again, very new, very interesting, very different, something kind of not the standard. And kind of, if I can maybe explain a little bit further, for instance, I know, Dr. Siegerman, in hand and wrist, you have the wide awake surgery. We did something earlier this year on another podcast, and we were talking about it, and I find that procedure interesting because it's done when the patient is awake. So, between Dr. Ahmed and Dr. Krueger, is there really kind of any sort of procedure that you all are aware of or that we're performing that is kind of on the forefront or something just, again, very different for our patients? It's not the standard.
I think it's a valid question, especially in joints. We've certainly made some mistakes in the past, not Rothman, but the profession, in terms of thinking we had a great solution to a problem, and then it turns out the solution was worse than the problem at hand. So I think, at Rothman, we use a lot of evidence-based medicine and try to ensure that we are, following the best practices. Certainly, we have a lot of surgeons here who help design some of the newer techniques and some of the newer technologies. Some of those include robotics that we use, or navigation and things along that nature. But we also study them, quite closely to make sure that, we're using them appropriately, and that any patients are getting these new technologies, we're actually, again, making sure that they're in good hands. So anyway, that's a long way to say there's always new innovations. However, the excitement I kind of hold in place until we know that patients are definitively getting better from them.
Yeah, I definitely second what Chad's saying. And, not all brand new technology is going to make things leaps and bounds better. For my practice, what's really kind of changed things recently is the intraoperative CAT scan, to be able to make sure that what we're doing is exactly perfect for the patient when we're fixing fractures around the acetabulum or the pelvis, or even the ankle. We've been using the intraoperative CT scan to make sure that everything's just right. And then with the patient already on the table, we're able to change it right then and there very, very easily. So that's one thing that we've been doing lately.
I think, for hand surgery, there's a few things. You touched upon the wide awake surgery component, which I use often. One particular area where that works really well is with tendon repair and tendon work. So there are two indications. One is when we repair tendons, someone's tendon gets cut because it's lacerated, they're unable to bend the finger. And then it's sort of a complex operation because the tendons need to glide very smoothly through pulley systems. So when we repair them, before we had wide awake surgery, there was a little bit of a question of whether it was going to glide nicely. So all we do now is we just tell the patient to make a fist. And if they can do that nicely, open and close their hands, we know that the repair has been successful before the operation is even done, before the skin is closed. So that's really, really special. And then, other advances in hand surgery, there's a lot actually. And one thing that I'm really interested in is nerve repair and nerve work. For instance, I had a patient who cut his ulnar nerve. He's an adolescent individual, had a horrific trauma where his ulnar nerve was cut in the forearm. And so what we were able to do is transfer one of his nerves that he had in his arm to the ulnar nerve to allow it to start getting better quickly, and then used a donor nerve from a donor, and then repaired it with something called an allograft because it wasn't able to be repaired primarily or just end to end. In the past, we would have had to take a nerve from his leg, which would have left him with a patch of numbness, and sometimes people don't do all that well with that. But this patient had a tremendous recovery, and it's not uncommon for them to have really, really good recoveries with newer advances such as these nerve allografts and things. So in my particular field, I think there's a lot of advancing things. We're always changing, and what's great is that at Rothman, our group is studying a lot of this, and so it's not uncommon for me to sort of reference the papers that our group is working on, to the patients, and I can print them out for them and show them. Not all of them are done here, but many of them are. So that's really gratifying to be part of the research team, have our patients, with their permission, enter some of these studies, and then come around full circle to where it has an impact in the way in which I treat patients. Really gratifying.
Awesome. So.
And Alex, I'm actually in the OR now, speaking of life in the OR, and I got to go take care of another patient. So I got to bounce off this, podcast really quick.
I appreciate that in the typical, being on-call physician, and patients and listeners are kind of getting the real life of a surgeon. So we'll absolutely let you go, and we appreciate you joining on, and absolutely please go take care of that patient.
All right. Thank you so much. Atif, Dan, you guys take care.
All right, thanks, Chad. Take care.
All right. Bye.
So I always, anytime that we do these podcasts, we always say this is really like who we are. So a lot of things, obviously, we can't, fully prep for, and, that's the situation. So it kind of just gives people an inside look of being an orthopedic surgeon and just being on call. And again, just kind of at a minute's notice, having just to kind of go to attend to something. So no issue there. But I'm curious because I want to know, how are you prepping? Like what's a typical day, an OR day look like for you all? So what time do you get up? How long are you there for? How many cases will you see a day, if you have any, on a typical OR day?
Yeah, so, I operate 2 times a week. That's Monday and Fridays for me. So that starts Sunday night, Sunday afternoon. I usually, review the cases in detail, review everyone's imaging, go over some of the details, ensure that all the equipment is going to be available. We're really diligent about that, and our team is really good too. But sort of rehearse the operation, the day before to ensure that all the T's are crossed and the I's are dotted. OR for us starts at about 7:30 in the morning. So I wake up about 5:30, 2 hours before, maybe between 5 and 5:30. Get ready. Always a big Starbucks fan. So
what's your drink order?
Venti iced coffee all year round, even in the winter. So,
okay. That's important.
That has to happen or there will be no OR.
Cancel the day.
Exactly. So get in there with plenty of time, meet the patients, talk to them, talk to their family, make sure they're comfortable. Everyone's anxious before surgery. And I think it's important to spend that time before surgery, make sure all of their questions are answered, make sure that all of their post-operative concerns are answered. Will they have a sling? Will they not have a sling? Will there be any pain medication after surgery? What they can and can't do. Make sure that their family understands what they can and can't do. I think that's ultimately very important. Often it's not uncommon for me to set up therapy during that conversation too. So if they need post-operative therapy, oftentimes with hand surgery, you need to get things moving very quickly. Mm-hmm. So I set up their appointment for therapy sometimes before the first time they see me back in the office. And we try to set that up, before the operation. And what's interesting is we're kind of going back to this routine, but for a while here during the pandemic, that has been altered because family members weren't allowed in to surgery. And, that conversation was difficult because they were on the cell phone or they were outside or they weren't there and there was extra anxiety. So I made it a priority to make sure everyone was, involved to the best of our abilities, given the pandemic restraints. But now we're back. And so that's a typical day. And then we have anywhere from a handful to many cases over the course of a day. And, at the end of the day, all the documentation gets completed. And I typically will call my patients the same day of surgery just to make sure that they're doing okay. And if we can get a hold of them, great. Sometimes they're sleeping off their anesthesia or they don't recognize my cell phone number or something like that. But within 24 hours, we're always, in constant communication to make sure everybody's doing great.
Great. Thanks for sharing that.
Yeah, so for me, the trauma program is very hospital-based. And so I usually spend about probably 80% of my time doing surgery. A typical surgery day, I'm in the hospital about 6 o'clock in the morning. And the OR will start at 7:30. And so that first hour and a half is really important because nothing that what I do is really scheduled. Everything is there in the hospital and I'm walking into it. But the hospital and the system is a very well-oiled machine in the sense that it can handle that, and the machine is designed to be able to accompany. I get the list of patients of everybody that came in overnight. You then triage that list of who has the problem that needs to be taken care of most urgently. Those are the patients that get put on the OR schedule first. And then we go from there. And so depending upon if the ER was busy the night before, it could be a lot of cases on for the day, or if no one came to the ER, there could be just a couple. And so sometimes I can end my day at as early as 3 or 4, or I keep going to like midnight or 2 or 3 o'clock in the morning, just to make sure people get taken care of in a timely fashion. But like the beauty of trauma surgery is that you never know what you're going to walk into. Sometimes I walk into the hospital and I have to fix like 5 femur fractures, or there's a couple of forearms, or, it could be, every day is different. You never know what you're going to get.
So Dr. Siegerman, he actually alluded to this a little bit because I say this at every episode that we have to talk about the pandemic, and I promise in 2022 we will not mention it anymore, hopefully. But curious, in your experience, like what has been the biggest adjustment in that sense for you?
Yeah, I think dealing with the patient's families is the hardest thing. I think a very important part about surgery is to make sure we have open line of communication. And when someone's injured or someone has a problem, sometimes they rely upon their families to really fill in the gaps, with some of the discussion, because sometimes when you're hearing it yourself, it's hard to compute all that information. For me, I distinctly remember patients being there all by themselves. They sort of got dropped off at the surgical center or the hospital, and they get picked up by their spouse or their, significant other or friend. And, they don't have anyone with them. So one thing that I did early on is, either our physician assistant or even myself just sat there with them, walk them into the operating room to make sure that they had someone there as an advocate, someone there to talk to, someone to shed a tear, someone to just sort of answer any last minute questions so that they were comfortable as they, embark on surgery. That was probably the number one biggest adjustment.
See, that goes back to our previous statement that surgeons are people too, and that they actually care about their patients. That's a prime example.
For sure. Yeah. And I mean, for me, during the pandemic, the first part was actually really scary when in March of 2020, when no one really knew what COVID-19 was and how to treat it and how to prevent it, mitigating the spread. And so as the trauma doctor, these patients come in and they're hurt really bad and they need surgery and they're COVID positive. And so then you have to get into the full protective gear. You're kind of putting yourself at risk because now you're exposing yourself to this disease that no one really knows about. But, in the end of the day, this is what we signed up for, So we do our due diligence and protect ourselves best we can, and we're there to help the patients. And so that was really tough to deal with in the beginning. But as we got more information about COVID, and COVID has now become something very routine in the hospital almost, where we have set algorithms and protocols and we know what to do and how to prevent the spread, that it's gotten much better and we're much, much better at it for sure.
And I'm just curious for you, especially, we mentioned that you're part of our Rothman, Florida team, but you actually started, at our Greater Philadelphia practice. So for you, how has that adjustment been? You were up here and then now you're down there. So the good, like you have on your side that you're part of Rothman, so you already know how we work and what goes on. So has there been such a huge change, learning kind of like a new hospital, and their best practices and all that? So explain a little bit how that's been for you, that adjustment.
Oh yeah. I mean, anytime change comes in your life, it's always a challenge, but it's been a welcome challenge and it's been really great. So Advent Health partnered with Rothman Orthopedics to be the sole orthopedic provider for their hospital system. And their hospital system is actually really huge in the Central Florida area. There's 17 hospitals in total that are Advent Health hospitals all across the state. And so they have been very receptive, and since the partnership is so good that they've actually brought on the Rothman administrative people that have put into place the mechanisms and best practices from Philadelphia and New York. And we're now bringing them to Florida to bring our high standard of care into Florida. And the hospital is completely on board. And it's been a great, great experience so far.
Do you miss us at all in Philadelphia?
I mean, a little bit, sure, but the weather here is so good.
Okay. It was just a simple yes, you miss us, and that was...
Yeah.
So I have one more question before we get into like our fun little rapid fire questions that I want to ask you both. But what would you say is the best part of your job?
I mean, for me, it's helping people in their time of need because they're hurt. The day before they see me, their life was perfectly fine. Everything was great. And then the day they see me, they had some sort of horrific injury. And there's a lot of questions of, when can I go back to work? When can I go home? And they're in a lot of pain too. And so getting people through that and then getting them out to the other side where back to where they were before is really gratifying, and it makes it all worth it. The long days, the stressful procedures or stressful times. And when you see a patient coming back and they're doing great and you got them through that, then it's all worth it.
Awesome. Dr. Siegerman, what about you?
Yeah, I echo that. Two things. The coolest thing about my job, I think, is to walk into the office and meet, 30 to 40 some odd patients that I've ultimately never met before. They have a problem, and I just get to meet, really nice people and try to help them. And so I think that's a special part of what we do. I think, one of the most gratifying things that I love is, when we do a bigger operation for someone, we really improve upon their function. We change what they can and can't do and give them function back. There is something about that is very special, and you can't really describe how great that is. And they just say, thank you. You keep in touch. And for instance, I had a gentleman who amputated 2 fingers, and we did a replantation of his 2 fingers, and I mean, that's incredible, and what's funny is that patient sends me a text every year. It's in January sometime, saying, this is the 3rd or 4th or 5th anniversary of the replantation surgery. And I never expected it coming. It's usually like in the dreary part of the winter, and it's kind of nice. And so those are the gratifying moments.
Great. Thank you both for sharing that. So I wanted to end really quickly. It's just something we like to do. It's kind of a few just fun little rapid fire questions. So obviously you guys don't know about them, but just fun, just kind of make you think on your toes a little bit, and a little bit separate from the topics that we discussed. But just feel free. I'll just kind of throw it out there. Feel free to just jump in. It doesn't have to be long or drawn out, but just want to see a few things. So the first question, any superstitions or rituals that you must do before you go in the OR?
I don't really have any superstitions before, but I have superstitions during the surgery that I do. Like, for example, when we're fixing a hip fracture, when we put the implant in, which is usually a rod. The rod comes with a targeting device where you can put the screws in through the device. And so I always check it on the back table. It never misses, but everyone asks me, why do you just keep doing this? I'm like, well, these procedures always go well, and I always do it like this, so why should I change?
Yep, that seems like a good one. Dr. Siegerman, you have any?
Mine is kind of simple and sort of silly, but at the end of every operation, with our bloody gloved hand, I always give the surgical tech or the assistant a big high five.
There you go.
And that's just funny.
What's your favorite way to decompress after being in the OR all day?
Well, I work in New York City, so usually it's about a 2-hour car ride home because of all the traffic. But
so you have 2 hours to decompress, actually.
but in all seriousness, I got little kids, so when I get home and they give me a big hug and they ask me how many boo-boos I fixed, that sort of gets it going. But
yeah, for me, my wife and I, we don't have any kids yet. One's on the way. So we have a dog, Bernedoodle, which, it's always great to come home to the dog who's super excited to see you. And so that was in Philadelphia, but now I'm in Florida, so I just go to Disney World.
Oh, all right. That's a great way to decompress.
Oh, it's been amazing.
Yeah. I mean, like, what are you doing this weekend? I'm just going to Disney. You can go to like different parks, right? Like visit one park, one weekend, right? No rush.
Yeah. Well, I visit multiple parks in the same day. Sometimes I'll start out the day at Epcot and then end up at Magic Kingdom or, whatever I want to do.
Right. Well, that's a good way. Last question. What would be your walk-up song going into the OR to get you fired up, to kind of get you moving? I know you both have one.
I'll let Dr. Ahmed go first.
So I'm a big techno guy. So
okay.
There's a song, I forgot who the artist is, but the name of the song is Mama Look at Me Now. And it's just about this kid who's who's made it, and no one believed in him when he was like growing up, and he's just like, oh, look at me now, I've made it, and I'm like, I'm successful. And so that I actually end up playing on my way to work a lot too, because a lot of times it's 5 o'clock in the morning, there's no light, and I'm like, what am I doing? And I'm like, oh yeah, no, this is what I've always wanted to do. This is great.
Yes. Techno at 5 a.m. is the perfect thing to get you. That's the equivalent to Dr. Siegerman's coffee order, is listening to that, I'm sure. Dr. Siegerman, what do you have? Anything?
Well, from a music perspective, I mean, we listen to a lot of music in the operating room, and it usually changes throughout the day. We usually start off with, Tom Petty radio and classic rock, and towards the end of the day, we might be into Jay-Z and Eminem. So maybe
I'm going to your OR.
Come later.
I'll come at the 5 p.m.
Yeah, I don't know. It depends. So it depends on the time, but maybe, who knows, Jay-Z, Empire State of Mind, or one of these old school Jay-Z songs.
The fact that we're saying that Jay-Z's old school now just says a lot.
Dating myself with the young people now.
I know. That's why I was like, wow. Before we end, I just want to give you guys last words, anything you want to tell potential patients, any closing that you have, feel free. This is your elevator pitch if you have one.
I think we've covered a lot here. I think one of the constant themes is that, we really, really, really care a lot about our patients, about their lives, about their injury, about how they do, about how it affects them in their work and their families. So, if you're injured and you have, pain, that we can help. We really care about the whole patient, not just that injury. We care about getting them better and making sure that they're happy.
Yeah, definitely. I definitely want to echo what Dan's saying, is that it's, at Rothman, it's really special in the sense that we are a center of excellence for orthopedics, and the practice model is really driven on everyone specializing in or focusing on their specialties, so that we do those things very, very well. So amongst all of us, if you have a problem, an orthopedic problem, somebody at Rothman can help you. And if it's not me, I have a ton of other partners that I know that if you have a rotator cuff or hip arthritis or other types of problems that I know would be handled by somebody that's even more qualified or better qualified for that specific problem, none of us really hesitate to involve our partners and really put the patient first of what they need. And so, Rothman's really special in that regard.
Great. Well, I want to thank Dr. Siegerman, Dr. Ahmed, and Dr. Krueger, who obviously had to jump off earlier, for your time and just giving us a little bit, a deeper look into what you all do every day. Thank you for that. I'm always just at awe at what you all do, what you study to do, and how you literally fix people and make them better. So, again, thank you for your time today, and thank you for all you do for Rothman.
Thanks Alex, for setting this up. It's great.
Yeah, this has been great.
We'd like to thank Dr. Ahmed, Dr. Krueger, and Dr. Siegerman for joining me on this episode. We're on Spotify, Apple, Google, the Rothman Orthopedics YouTube channel, and a few other listening platforms. So make sure you download, subscribe, most importantly, share on whatever platform you utilize. Thanks again for listening, and until next time, take care.